I did put a message out. I hope you got it. I know I said 7:30 to 8, and it's now, well, let's just say past 8. I feel like my face is buzzing. Does it look like it's buzzing? I fell off several times, went out on my bike, and went into a load of nettles. My face hit nettles. I feel like it's all like tingly, but cracked my helmet. Thank goodness I was wearing a helmet. I tell you, I felt the crack over the handlebars. So many, honestly, terrible. Absolutely terrible at my age. Absolutely terrible. Anyway, hey ho. Went out with my son. You see, he likes. I love it. I love mountain biking. I've been mountain biking for years, but I don't know. You could say I should know better. But anyway, absolutely exhausted. Did a ride that's supposed to take 2 or 3 hours. Probably took us more than that. Anyway, that's why we're home so late, because he's waiting for me. There you go. Well, let's just, enough of the banter. I know what you come for. I know what you want, guys. You want some questions. You want your questions answered, don't you? Yeah, that's what you want. That's all you're after, isn't it? That's all you want, and that's what I'm going to give you. How about this one? Do we offer the internal mesh technique? Candy's in the house. Now, the internal mesh technique, I do happen to know what this is on about, because I was around when I might have even answered this inquiry. But anyway, this was an inquiry about a breast lift. And it was a bit of a weird inquiry, because I think the patient said that they'd been to London, and the person had recommended. Oh, I've got bruise. Can you see that? Is that a bruise on my hand? Flipping heck. See that? I've got a bruise on my hand. It's wearing gloves and everything. Anyway, the person had recommended an internal mesh technique. Do I offer it? And I don't. The answer is no. So the short answer to that question is no. I don't offer it. What we're talking about here is mastopexy, breast lift, potentially also breast reduction as well, because one of the major limitations of breast lifts and breast reductions is to get the shape as full as patients would like. And obviously, people having a breast lift want their breast lifted and fuller up on their chest. But what happens is that whilst it is like when you first do it, it settles, and it settles to what I would call a more natural shape. But it does settle to be emptier in the upper pole after time. And this is something I do try and make a point of, letting patients know this prior to surgery, so they can make a decision whether they want surgery or not, because I don't want them thinking they're having a breast lift and their breasts are going to be up here, and they're not. When people have an image of breasts up here, what they've usually got an image of is people with breast implants. So you can get the breast up there with implants. Implants, the volume does stay up there, but when it's your own tissue, it doesn't stay up there. So you put it up there when you do a breast lift. You put it up there, so when you first have the op, it's there, but gravity works on it, and it just I wouldn't say drops, but say drops then. Settles. That's the word, settles. So it is a real problem with breast lifts that the volume doesn't stay there. So if we could make it stay there, it would be brilliant. So the internal mesh is attempting to solve a very real problem. It's attempting to solve the problem of getting long-term fullness in the upper part of the breast following a breast lift. I don't do it because for me, it's not quite there yet. And I think you'll find, I might be wrong, but I think you'll find not many people do it, because I feel like saying, why didn't the guy in London do it? He said it. But anyway, there are several ways of doing it. There are several internal meshes that you can get. There's one that's like a cone that goes in underneath the skin. One of the problems of the cone is that you have to undermine quite a lot of the skin in order to get the cone in. Scone, and that can potentially cause problems with the wound healing of the skin, because if you're undermining a lot of the skin, you worry about the healing. You worry about the healing anyway with a breast lift. And if you do have any problems with the healing, and if that mesh gets exposed, it's a nightmare, because you have to remove the mesh, and that can be quite difficult. The other way of doing it is with a hammock, but the hammock has to be anchored to something, and that something has to not move, because if the thing that the hammock is anchored to moves, it all sags down. So usually that means anchoring it to bone, so putting little bone anchors into the ribs, which is fine, but then it can potentially cause problems with pain and discomfort with those bone anchors pulling. And again, if you have for any reason want to have the mesh removed, if it became exposed or infected, or if you didn't like if you have discomfort from the pulling, it's extremely difficult. So it hasn't really taken off, to be honest, and it's not something I've embraced, but it is a technology that's out there and people are working on, and fair play to everyone who is trying to, advance the specialty. I think it is great, but for me, it's not there, and there's too many risks associated with it. So I don't do it, but it is a thing. So it is a thing, and it is a real problem. And if it could get the volume to stay up there, then that would be a very useful thing indeed. Candy's asking, can you do a breast lift twice? That's a depressing question right there. I've got to be honest. That's depressed me. That is a right depressing question. That is. What she's saying there is, done a breast lift, and I want it back up again. So Candy, I'm going to answer that question in general terms. In general terms, the answer is yes, you can. If the breasts sag again, if the nipple drops again, you can do it again. The only thing I would say is you need to know the original pedicle. So if you are having a different surgeon, you need to get the original surgeon to get the op note. Now, most of us will give the op notes. The hospitals will have op notes, and your surgeon should be able to get your op note off the other surgeon. So that's not a problem unless it's ages ago. But the thing that the thing is, sometimes people want the breast lift to give that fullness, which is what you get with implants, and you can't get that fullness. So you've got to look at the position of the nipple, and if the nipple on the side view is in a good position, if the nipple's in the middle of the breast, if it's pointing forwards and not pointing down, if it's not the lower part of your breast pointing down, we look at the inframammary fold, total side view. If the nipple's in a good position, it's the shape of the breast. That's a natural shape of the breast. And so that is the problem when you're in people who maybe have had a breast lift and are not happy with the degree of lift it's given, because to do it again will possibly give you the same result. It will put the volume up there to start with. You'll think happy days, I'm happy, and then it'll settle again. So if the nipple's in a good position, I would not recommend doing another breast lift, because I don't think you need another breast lift. I think you need to either say I'm happy or not happy. Obviously not happy, basically an implant is what would give the volume up there. You might say I don't want implants. You might say I want fat. I want to inject fat in there. Fine, fat is natural tissue as well, and it's brilliant for giving volume. Very mild volume, not huge volumes. Very mild volumes can be given with fat, but again, that will settle as well. It doesn't give you sustained fullness. The only way to get sustained fullness in the upper pole is with an implant or a bra, push it out with a bra and things like that. But I know I can hear you. I can hear where you're coming from. But there are risks associated with doing any sort of revision or second time surgery. And so I wouldn't take them on unless you could think that you're going to get some really good results, and I would be worried about that. Candy, Jackie's here. Sorry, I'm late, Jackie. So I hear what you're saying, though, and I'd be very happy to talk to you in real life about this. I'm always happy to talk to people in real life. I do real life talking as well as this sort of talking. So if that is something you want to talk about, I'm all for it. Look at that, I've still got the internal mesh question up. Diameter. Yeah. Good question, Candy, but has left me slightly empty inside. Anyway, on a lighter note, can a tattoo located right under the eye be removed with excision? Now, I saw this tattoo, and you know what I say to people? I want them to ideally let me show their photo, but I've got no indication this person's let me show their photo, so I better not. You know what? I'm all hot and sweaty. I'm getting my pillow all hot and sweaty. So better not show the photo, because in general terms, can a tattoo located right under the eye be removed with excision? Well, yes, it can. A tattoo anywhere can be removed as long as there's enough laxity in the skin, so that as long as the tattoo isn't too big. So it can be. So the question is the size. the size of the tattoo. And the problem with the lower eyelid is it's different to the upper eyelid. The upper eyelid, there's a lot of skin. Ow, there's a lot of skin in the upper eyelid. People do blepharoplasty, upper lid blepharoplasty, take out quite a lot of skin. Lower lid, you've got to be really careful. So lower lid blepharoplasty, much less skin is taken out when you do lower lids because there's a risk that the lid can be pulled away. Not a good look, is it? You want that? Who wants that? Hands up if you want this look. It is not a good look. It's called ectropion, and it's when the lid is pulled away from the globe. So you've got to be really careful cutting skin out of the lower eyelid. And this person who has sent this tattoo, I think it's a little bit too wide. It's just underneath the eyelid here. And yes, we can remove lesions under the eyelid, but my worry is it'll take out too much skin. It'll pull the lid away from the globe, and if you pull the lid away from the globe, it's called ectropion, which is the lid not sitting on the globe. And because you've got your milk duct, doing too much breasts. It's not a milk duct, is it? It's a lacrimal duct. Okay, you've got your lacrimal duct. You've got your tear duct down here. As you can see it, it'll be right and left. It's in here somewhere. It's down here. Probably can't see it. Doesn't matter. It's there anyway. There's a tear duct there. Because you've got a tear duct there, when the globe and the lid are not effaced, the tears don't run into the tear duct, and you get something called epiphora, which means that the tears run and then they run down your cheek. So it is a bit of a problem, basically. If you get an ectropion and epiphora in cold weather and stuff, your eyes tear basically, and you have tears running down your cheek. So you've got to be really careful with taking skin out of the lower eyelid lid. Bottom line. Have I said, is the sound working on Facebook yet? Is the sound working on it? I've not said it. I'm assuming it's working. I'm going to put a question on. Anyway, I'll finish this one and then I'm going to put a question up on the thing. Yeah, epiphora is a worry, and ectropion is a worry. So lower eyelid skin, really careful. So I'm sorry I can't show you this photo of this tattoo, but anyway, my view, it was too big to be excised. How can I can type something? Is working? Is that? Bit of an amateur move, I know, but it has not worked before. Instagram's never a problem. Facebook, it hasn't worked before. It's working, Simone. Thank God for that. Bitter experience of talking to myself for 20 minutes and then someone says the sound's not working. So there you go. Thanks, Simone. Thank you. What am I doing now? I'm doing another question, and this question here is, what is the recovery time for scar revision? Last week I had a recovery, because I've got all the questions here. What was the last week recovery time question? It was pinoplasty, wasn't it? I guess pinoplasty is a bit niche, a bit different. But I'll tell you what, recovery, well, one of the things about scar revision is it can be a huge spectrum. You know, scar revision, geez, what, small little scar they don't like, big scar on your abdomen or on your back or on your, you know, what it covers quite a big spectrum. So broadly speaking, when you do surgery, when you stitch up the skin, broadly speaking, the skin is healed in 4 days, 4 to 7 days. The skin is healed. A little bit depends on the area. Face heals really well. Ankle doesn't heal so well. So, you know, maybe 2 weeks for your ankle. Back doesn't heal so well. You know, 5 days for the face type thing. But anyway, 5 to 7 normal skin's healed. So your skin's going to be healed in a week. If it's a small thing like on your face and it's not under a huge amount of tension, I mean, recovery time, you might be able to go to work the next day. It might be a local anesthetic thing. Usually, I would say most scar revisions are local anesthetic things, relatively minor procedures. So you have dressings. You may or may not have dressings if it's on the face, but you'll have what will you have? Well, you have stitches on your face. You have stitches on your face and stuff like that. So you might not be able to work with stitches on your face, but if you can work with stitches on your face, yeah, you can go back to work the next day, to be fair. you know, we can give you some tape to cover them up. You don't want to get too hot and sweaty. You don't want to go and play football or do, you know, some kind of contact sport for maybe 2 or 3 weeks. Scar will be obvious for a few months. You know, it does take months for the scar to fade, but usually it's a relatively minor procedure. If it's a GA, might be a bit more involved. Normally do a dressing clinic at 1 week, so you might that week might be off, because if it's a GA, you'll probably be a bit knocked back. It just suggests it's a bigger scar, bigger op, so maybe the wound's under tension. So we'd maybe say to you, take it easy for a week, check the wound at a week, see how it's looking, and then maybe you can start getting back into things. But same thing with the scar being red and obvious for a few months. That is the thing, you trade in often a very mature scar for a fresh scar. So whilst we try and fix the problem with your scar, whatever the problem may be, lumpy, raised, dented, the position of the scar or whatever, it will be probably more obvious to start off with before it gets less obvious. So this question here says, can you have breast augmentation whilst going through menopause? That, my friends, is a lovely cup of tea made by yours truly. I do like a cup of tea. Yeah. Oh, yeah. Yeah, you can. I mean, the only thing, why not? I would say. I mean, what's I don't know. The only thing about that is if you are having hormone treatment. If you're having endogenous hormones, so hormone replacement therapy, then that could affect your risk of blood clots, which would be an issue with any surgery. Some people stop HRT. I don't. I carry it on, but we do things in place to make sure you don't clot. Well, I think everyone does things in place to make sure you don't clot, don't form a DVT, which can fly up into your lungs and form a PE. So that's the only thing I would say about breast augmentation whilst going through the menopause. But that's not so you can still have it absolutely fine. Like, just get moving, but you should get moving whether or not you're going through the menopause. So movement is good to stop clots. But apart from that, yeah, absolutely fine. No problem. No problemo. Simone, straight in. Well, maybe not straight in, but is it normal to have a swollen upper abdomen after a TT? The bottom is flat as a pancake, but under breast ribs area is quite big. Looks weird. Yes, Simone, thank you for that. So I wouldn't say it's normal, but what happens? A couple of things. So first of all, when you do a tummy tuck, you go up to the rib cage. You go quite high up to the rib cage to undermine, to pull the tissues down. So it's not unusual to get swelling in that area. Also, not the problem, but one of the things about binders or garments is they have to stop somewhere, and you often get swelling past where they stop. So they often don't get too high up there because they get into your breast and all that sort of stuff. So, where the binder stops, there can be swelling sort of either above it or on your hips. Sometimes you can get it below it. So, so you can get swelling aside from where the binder is. So the binder might be doing a good job with the lower abdomen, but you might have a bit of localized swelling here. Bottom line, Simone, if you're worried, send us a photo or come to clinic. We'll have a look. But yeah, it is. I wouldn't say it's normal, but it's not like there could be a reason for it being the fact that there's, well, first of all, there's undermining going up to the rib cage, so there is surgery done in the upper abdomen, so it is normal to get swelling in the upper abdomen as well as the lower. But it might be that the binder's doing a good job with the lower, but is not really giving as much compression in the upper abdomen because your breast is there and things. But bottom line, if it looks weird, Simone, I mean, to be honest with you, I think if it's not that long after surgery, it often looks a bit weird. But if it does look weird, just send us a photo or give us a ring, or and we'll have a look to see if it's a normal weird or an abnormal weird. That's the bottom line, Simone. Is it a normal weird or not? Because if it's not, then you need to come in. But if it is, then you need to not worry. The menopause, breast augmentation. When can I return back to work / drive after breast augmentation surgery? So again, I say again, but it depends on, I'm sure there was a depends on question, or there was a scar revision. Depends on what you do for a living, really. So driving, you got to check with your insurance company, because your insurance company sometimes say it's got to be a certain amount of time after surgery. I normally say 2 weeks, give or take. It depends whether you have it under or over, because it's a little bit more uncomfortable when you have it under the muscle compared to over. But broadly speaking, wherever you have it, under, over, or whatever, first week you're going to feel a bit not good, a bit swollen and not very great. The second week you'll be feeling better. You know, and you might be able to drive in that second week, but it's safe to say 2 weeks for driving. And even then, obviously, you have to wear the seatbelt and you have to do an emergency stop and all those things. So see how you're feeling. And if you're feeling okay, then 2 weeks is normal. Work, so often you need to drive to work, so then that might be the 2 week thing. So again, 2 weeks is sort of normal while you're driving and stuff, but you're still going to feel sore, you're still going to feel uncomfortable, you're not going to be 100% at 2 weeks. So you can go back to work at 2 weeks, but I wouldn't go crazy with doing anything too heavy. If your work involves heavy lifting or moving things and things, what we can do is we can give you a sick note which says that you can go back to work, but light duties or phased return, sometimes sort of adjusting the hours and things, because you will feel quite uncomfortable and quite swollen and tense for about 6 weeks. 6 weeks is when, you know, normally you can start getting to lifting and using your arms, putting power through your arms. So, you know, obviously you can do desk job at 2 weeks, but if you're you know, working in the warehouse and lifting things, or, you know, doing some kind of manual thing like a nursing and things with manual handling and what have you, you don't want to be doing that for about 6 weeks post-op, just because you're going to make it swell. So thanks, Simone, for asking a question. I would say, you know, good to have someone, you know, to be quite honest with you. I've got to be honest, this late night hasn't worked, has it? Has it? I don't know, maybe I shouldn't be too negative. I didn't deliberately do it late night. It's just circumstances beyond my control, because we couldn't cycle the bikes fast enough and get home quick enough, because there was all these hills everywhere. Oh, the hills. I tell you what, I need one of those electric ones. I've hired one once. My son was not impressed, though. I'm thinking of even less. What's the word? Anyway, I think less of me, basically, if I had an electric bike. Anyway. They often don't look, you can, the motor's hidden, but it goes whir. I think I couldn't get away with it. Anyway, let's do this last question here, guys. Fair warn, last question. If you've got a question, if you're sitting on your question thinking, I'm going to wait to the natural break before I ask him the question, you might find that this guy's gone, right? So get your questions in before this guy goes and has a shower, okay? So get those questions in soon. Don't worry if you do miss it, because you can always post them and I will answer them next week. Yeah, that's right. Do it every week. Madness. Do we offer surgery for saggy chin? In a word, that's another one-word answer, potentially, and the answer is no. I'll expand. I will expand. There's certain areas in this world, in the body, which respond well to liposuction. I always talk about the central tummy not being a good place for liposuction. Hips, flanks, sides are good. Lateral thighs are good. Chest is good. And here, chin is quite a good place for liposuction. So you can do liposuction to the chin. I mean, the problem with the saggy chin is, like with any sort of body contouring surgery, is if the skin, you have to look at the quality of the skin. So if you've had a lot of sun exposure, if you're a smoker, your skin might not recoil. So you can take out fat from the area, but if the skin doesn't recoil, you're not going to be happy. So then you have to look at excisional procedures, which mean more scarring, which means facelifts, pulling and things like that. You can actually do it directly on the chin, but often a facelift you can pull up the neck. But we don't do that sort of stuff, because we just do breast and body contouring. So breast and body contouring is the forte of Z Clinic. So we don't do surgery for the aging face. We don't do rhinoplasties. That's not surgery. But anyway, we don't do nose jobs or facelifts or things like that. But it can be done for the saggy chin. And Corinne has... is it a question? Hi, JJ. Looking forward to meeting you on the 10th of September for my consultation. Not a question, more of a statement. But Corinne, I am very grateful for your statement, and I'm very much looking forward. Corinne, they told me you were coming on the 10th of September, and since I heard the news, I've been beside myself, and I'm counting down the days. What is it? 10 more sleeps. Can't wait, Corinne. Very much looking forward to it. Amy, not a question. Again, another statement, but using the hashtag AskJJ. So, Amy, you're there. Okay, you're there, and you're putting the hours in. So, Amy, peace be with you. Yeah, thank you for that. Nicole, this actually might be a question, guys. Hi, JJ. I had an arm lift in May. The scar near the elbow is hypertrophic, tension from bending, I think. Would a revision have same result, or are there better treatments? Nice. That's what we need, Nicole. Nice, juicy question like that. Nicole, I don't think I did your arm lift in May, number one. So I think I'm not your surgeon. So number one advice is always speak to your surgeon is the best bet. I will answer the question though, so I'm not going to dodge it, but I just a bit worried about sort of giving advice on other people's stuff, because May's not that long ago, and really your surgeon should be sort of looking after this. But just in general terms, so not saying what you should do, but in general terms, hypertrophic scarring is often due to delayed healing. So you're saying it's due from tension from bending. If the wound opened up a bit and you had a bit of delayed healing, that might be a reason for it. Or some people can develop hypertrophic or raised lumpy scars. The first thing I'd be thinking about, if it was me, is I'd be thinking, is there a reason for this to be hypertrophic? Has there been delay in the healing? Has there a reason for it to become hypertrophic, or is it your body forming hypertrophic scars? So if there is because the worry is if it is your body forming hypertrophic scars, you worry about doing a revision, because as you say, it will, could potentially have the same result. Because if your scar looked great, when you first had it done, and it's become hypertrophic over the time, we could revise it. It'll look the same as how it looked when you first had the surgery, but then over time, what's to stop it from going hypertrophic again? So that's number one thing. If there's a reason for it being hypertrophic, most common being delayed wound healing, infection, if the scar, particularly if it took more than 3 weeks to heal, then there's a much higher risk of it becoming hypertrophic. So if that happened, I'd be more inclined to think about a revision than if it just healed fine and it's just gone hypertrophic for whatever reason. As a rule, we shy away from surgery on hypertrophic scars because, as I say, it is often because of the way your body's healing. So it's your body healing too much, basically. And so we worry about doing surgery to create another scar which could go hypertrophic. So we tend to focus more on non-surgical treatments. First of all, and something I tell everybody with scars, moisturize and massage. Number one, moisturize and massage, go for it. Normally at 6 weeks, I get people moisturizing and massaging the scar. That can help. Next step after that is things like silicone, which can come in gels or sheets. The sheets are probably better, but the gels are a bit easier to apply and manage. And so on your arm, it might be uncomfortable, or not uncomfortable. It might be difficult to get the sheet to stay. They are sort of adhesive, but it might fall off, so the gel might be better. But silicone can help. You can't do silicone and moisturize and massage. You do one or the other, because if you put silicone gel on, then moisturize and massage it, you'll rub the gel off. If you do use the gel's got to be on 23 hours a day. Take it off to wash, but all the time you have gel on it, and that can help. The next stage, depending on how bad it is steroid injection. That can help, particularly if it's itchy. They're often quite itchy, and the steroid can help with the itch, can help with the red and raised nature of it. And then you would move up to revision surgery after that. But you would probably try the non-surgical things like the steroids and the silicone first. And time. Often hypertrophic scars are self-limited. self-limiting, but they can take 18 months to get there. So it's a question of getting you through that 18 months. You know, it can take a long time for them to get better on there, but they often do get better on their own. And it's just a question of trying to manage it as much as we can. As I say, if there's itch and stuff, the steroids can help, silicone gels and sheets and things like that. But that's the sort of my mind process on that one. Jess, good evening. So glad I've managed to catch part of this live. Well, Jess, well, that's very kind of you to say. It's a bit late because I'm late tonight. That's very kind. That made me feel better because I had a, you know, it's been a tricky one. I'll be honest with you. Nicole, I've done that. Corinne has been very kind. I'm really counting the days down. I can't wait. Look at that. Corinne and I can't wait to meet each other. Nicole, the incision line was fine for 6 weeks, then became hypertrophic. So Nicole, that makes me worried about doing further surgery personally, because that is your body saying I'm going to make a big red lumpy scar. So that is the concern about doing a revision on it. So yeah, I'd be shying away from a revision personally, Nicole, and I would be going down non-surgical things. As I say, moisturizer, massage, you can do that right now. Any sort of moisturizer you got, you know, get on it and give it a bit of pressure. Silicone gel and sheets, I'm pretty sure you can buy them from the shops, pharmacies and stuff. Sil gel, Seeker Care. God, we do one. What's the one we use? There's loads of them. I don't know if there's any one's better than the other. We got one with little balls on it. I should know what it's called, which is quite good. It's a gel, but it's got balls on it. But as I say, the sheet's probably better than the gel if it doesn't fall off. Anyway, bottom line is there's loads of. We got some on our website, just to plug myself. But even if you don't want to, if you want to go Boots, I think they're in Boots. And then the steroid injection would have to be given by your doctor. Best your surgeon, really. Get your surgeon involved. I'm sure they'd want to be involved. But that's only after the other things. Well, Jess, I hope it was worth it. Honestly, I do, because to be honest with you, it's you can see the replay, you can see what went on. Listen, guys, time for me to go and freshen up, as they say. Nicole, thank you, JJ. I have been using silicone gel and sheets. Okay, well then we're into the arena of the. Is it itchy, Nicole? Because if it's itchy, then the steroid injections can help. If it's not itchy, then they might still help with the redness and the raised nature, but it's just another reason to think about steroid injections if it is itchy. And I've got to be honest with you, Nicole, time. May, what's that? May, June, July, August. What are we now? We're nearly September. Nicole, it's only 3 months. So it's not that long. So I wouldn't be too sort of going in hell guns blazing, looking at really invasive stuff. I just give it a bit of time. I don't know how bad it is, I guess. It depends on how bad it is. But if it's not that bad, I would just keep going with the silicone maybe. And maybe if you don't find the silicone's helping, because it doesn't always help, that's the thing about silicone, you could try massage and moisturize, give it a bit of pressure and stuff. As I say, you can't do both. You can't do one or the other. But that would, I will definitely catch up the replay, Jess. Oh, I'm not sure if time might be better spent doing something else. I don't know if you can do it quickly. I don't know if you can do like +2 speed, but anyway. But yeah, Jade, do you get tired of Am I asking the same questions, Jade? Are they the same questions? I do get a bit of different questions, don't I? I do get. Have I had a hypertrophic question? Oh God. No, I don't, Jade. Do you mind if I call you Jade? Sorry, Amy. Not really. No, Amy. I do obviously my clinic. I mean, I do a lot of breast augmentation in my clinic, and so I do an awful lot of consultations where I'm saying very similar things. I'm not actually as sort of like tired of it as you might think, saying the same thing time. I feel sorry for the clinic nurse and stuff who sits there and she hears everything me saying the same stuff time and time again. But I'm not actually. I'm okay with it. Having said that, I'm thinking of doing a thing where like maybe doing like a video or something like that and getting patients to watch a video about the common procedures when they come to clinic, so we get a bit of consistency. But actually, I don't mind. I don't mind, Amy. Not from tonight, just in general. Yeah. No, I know what you mean. It is there is some. I've got to be honest with you, Amy. They put a question on the list. Do we offer earfold? Right. And I've got the list from last week. Was it last week? And I had exactly the same question. So I'm like, I'm not doing that question again. I did it last week. And just send them the clip. I'm not doing that again. So there is a bit of that. But one of the things about plastic surgery, there is nuances to lots of things, and there is a bit of variety. I mean, when I was training, I was looking at doing sort of bowel surgery and things. And when you do bowel surgery, you sort of do, quite similar operations. Left hemiclectomy, right hemiclectomy, anterior section. Um, a lot of surgeons like orthopedics, knee replacement, cardiothoracics, valve bypass graft. Cardiothoracics aren't even cardiothoracics; they're cardiac and thoracic. They even split. They don't even do lungs and heart; they do lungs or heart. So you can get quite a lot of repetition as a surgeon. You can get into a niche where you just do one operation. Plastics is one of those things where there's still a little bit of variety, although say I do breast and body, so I don't do faces anymore. Although I'm happy to talk about faces because I've done a lot of faces in my training. But there are nuances, and I still do struggle. I'll be honest with you, Amy. Getting folds right and things like that, getting symmetry right with breasts and implants and stuff like that, and revisions, surgery, and things can be difficult with scar tissue and what have you. So yeah, no, I don't know. No, I don't really mind it too much. Really. Must have some part of my brain maybe that doesn't mind just go. I think a lot of stuff, isn't it? I mean, imagine if you're working in a shop doing the till. I mean, that's got to be pretty repetitive, hasn't it? I think a lot of things, you think about it, most jobs really. But I don't mind. Mine's pretty. Thinking about it, mine's pretty good. At least I get breast augmentation patient, then a tummy tuck patient, then a mole patient, then a breast reduction. Bit of, bit of variety. Call me what you want. Yeah. You should do a frequently asked questions. You know what, Amy? I've got a frequently asked questions thing that we like, a little brochure, a little leaflet. So when someone inquires about tummy tucks or breast lifts or breast augmentation or gynecomastia, we've got these little things which we send out. So we have got them little booklets. They're little real life booklets, and you can download them as well. Download them as a PDF off the internet, off the websites, off the website, only one website. I don't mind. I'm terrible at taking information, so I feel more like I hear things more. Do you know what, Amy? It's really interesting, and I found this when I'm training. When you're training, you go through medical school, and you obviously do everything that there is to, everything about medicine, and then you say, oh, I'm going to specialize. I'm going to specialize in surgery. And when you specialize in surgery, you have exams for surgery, and what you find is that the stuff that they talk about in the surgical exams is the same stuff that you actually did in med school, but you're just doing it in much more. You've been through it already, but you're doing it in much more detail. And then you do plastic surgery, and you realize the stuff that they talk about in the plastic surgery exams is the same stuff they had it in the surgery exams, but it's just in much more detail. So I think the point I'm making, which probably this isn't a very good analogy, but anyway, is that you often have to hear things again and again, and then sometimes it goes in. I find that a lot. And then one time you'll hear it and you think, I've heard that before, but actually I've just understood it there. So there you go. There's an argument for repetition, but I do think there is an element of that in this sort of thing that you did, or you got an angle on it, like the menopause or the breast augmentation, the menopause. That's your angle, not yours, but this person who's asked the question, or inverted nipple and breast augmentation, or a breast areola reduction and a breast augmentation, or an areola reduction and a mastopexy. There's all permutations and combinations which is personal to you or to the people. So I think it is helpful, for people to get their questions answered. And sometimes, and I'm okay with saying things that I've already said. I mean, the earfold, I said it last week, so I'll draw the line there. But, very happy to say I understand that obviously there'll be questions which will be asked again. So I'm fine. Amy works at Costa, guys, so I might see you down there, and it's training. We're talking about boobs all day. I'm always amazed at how long it takes to make the coffee at Costa. I've got to be honest with you, Amy. I do go to Costa. I do like a Costa, but I like an instant coffee. And you know, the faff every single time, because we got one of those machines. We never use it. I just have an instant. Mind you, my wife does like the proper one. She uses a cafetiere, but I think it's too strong. I just like the normal one, instant. But it is a bit of a faff at the old Costa. I'm always amazed at how much they go through. We've got a massive queue, and each one they're going all that. Boom, boom. Good on you, Amy. Good on you. That's awesome. Well, look, Amy, thank you for that. Right, guys. On that note, this guy here is going that way. You know, exit stage left. If you got a question, get in there. Be sure to ask it. If it's been asked already, who cares? I'll answer it again. And I will see you here at 7 o'clock, hopefully 7 o'clock next week. Sorry about the lateness. 8:50, nearly 9 o'clock. Jackie, what are you doing, girl? You've got to go get... Oh, he's always here. I can't believe it, Jackie. Go and watch a bit of telly or something. Honestly. Amy, I feel you. All right, sister. No, that's it, sister. Right. Increase the peace, and God willing, I will be here Tuesday night, which is next Tuesday night at 7 o'clock. See you, Corinne, on the 10th, I think it was, if my memory serves. And Amy, take care. See you on the live, Jess. Jess, thank you, Jess. Thank you. Great audience this week. So much better than last week. Well done. Right, I'm going to check out. How do I check out? I know how to check out. I don't